with us this morning to kick us off, to give us a sense of what's happening in Washington and in the larger national debate. I'm going to invite Scott Shafer and our speaker this morning. Sarah, if you join us, please. Scott, I almost needs no introduction. He has done numerous commentaries for KQED. He is an extraordinary leader, policymaker, commentator, communications master, and really a friend to the community of the work that we're doing. Scott, welcome, and thank you both for being here. I'll let him introduce
Thank you, Sandra. Good to be here with everybody. Can you hear me okay? Yes, we're good? Okay, great. Sandra, your comments about the AIDS epidemic. It's amazing how much time has gone by since we worked together for the city and county of San Francisco, but seeing Susan Ehrlich out there earlier just a moment ago reminds me of what a family San Francisco and the Bay Area really are when it comes to healthcare. Since the election, you might have noticed, California has established itself as sort of the chief opposition in many ways to the Trump administration's agenda. We even have our own hashtag now, State of Resistance. But as much as we like to think of California as a nation unto itself, there was even a move to do a Cal exit that didn't pan out. But we do think of ourselves sometimes, and with some justification, we're the sixth biggest economy in the world if we were a country. That said, you know, what happens in Washington, we are not immune to those things, of course. And what happens in D.C. has a huge impact on us here in California, and never has that been more true than it is now, especially with regard to healthcare reform. And joining us today to help explain and interpret the nuances of what is going on in Washington, D.C. is a journalist who has been steeped in healthcare journalism for many years. She's a self-described health policy nerd. You know her as Sarah Kliff, of course. She's a senior correspondent for Vox.com. She covered healthcare for the Washington Post, Newsweek, and Politico before that. And she and I are going to have a conversation shortly, but we want to begin by having her share with us her own Cliff Notes, if you will. And then we'll get started after that. Please welcome Sarah Kliff.
All right, thank you. Thank you so much. Well, I'm so happy to be here, and Cliff Notes is a great way to introduce that. So thank you so much for having me during what is a very tumultuous time in healthcare. I will say this was a difficult presentation to get ready for because every time I would finish these slides, something would change and I'd have to restart them again. But luckily, it appears nothing has happened today that has made what I have up here out of date. So I'm just going to spend about 15 to 20 minutes basically walking through California's role in the Affordable Care Act and California's role in the debate about Obamacare repeal, and basically what we expect to happen next over the past few months. And when I started thinking about this talk and California's role in the Affordable Care Act, I thought a lot about this story I wrote for Politico in 2011. This was January 2011, about 9 months after the Affordable Care Act had passed. And when states really weren't sure kind of what this law would look like, what their role would be, did they want to start a marketplace? They weren't even thinking about Medicaid expansion, because that wasn't even optional at that point. We hadn't had the Supreme Court ruling. And I came out to Sacramento to work on a story about, what is the largest state in the nation going to do on healthcare? And I met with Diana Dooley, who was in I believe it was her first week in office. I met with her to talk a little bit about California's plans. And, there's something that she said to me that I've thought about a lot lately. She said she had had dinner with some folks from the Obama administration the night before, kind of talking to them about what she wanted to do. And the administration complimented her. They said, California is really becoming the pace car on healthcare. And what Diana said back, she said, we don't want to be the pace car. We want to be the lead car on the Affordable Care Act. And that really is the role that California has essentially come into. When I think of the role of this state, as everyone before me has been saying, is that it is an example of what the Affordable Care Act looks like when a state wants it to work and has the right geographic and economic conditions to get it to work. There are a lot of opposite examples right now, a lot that you'll hear about in the Obamacare repeal debate, places where Obamacare is not working well, in part because of economic conditions and in part because state legislators there just didn't want it to work well. But California is essentially, to me, the opposite of that. It is a place where people decided, we like this program, we want to make it work, and you guys have arguably done a pretty good job of it. So let's run through a little bit about what California's role actually is. This is one statistic that just astounds me. 1 in every 5 people signed up for Obamacare programs lives in the state of California. Right now, the Urban Institute estimates about 19 million people have coverage either through the private insurance expansion or through Medicaid. 3.8 million of them live here in California, which is in part because California is a large state, but it's still actually, a pretty remarkable figure. California is only about 12% of the national population, yet you guys have 20% of the Obamacare enrollees. And I think that really owes to specific policy decisions California has been making. Another statistic that I think really shows this is the Kaiser Family Foundation, who I know of some folks here, and thank you so much for a lot of the charts you've done that made this presentation possible. They look at what % of marketplace eligible folks are actually enrolled in coverage. They find that in California, 47% of the people who can sign up do sign up, which is well above the national average of 40%. It puts California in the top 10. So really, by a lot of metrics, California is doing quite a good job at this. And this was another map I like from the Urban Institute. This shows the % decline in uninsured rate by state. So this is how much your uninsured rate went down. And you'll see California is in this group of 6 states that have had their uninsured rate fall by more than half since 2014. And there's a lot more lighter states than there are dark states. And it really speaks to a lot of the work California has been doing to set up the Affordable Care Act. So that's one way to measure success at the ACA, is how many people are signing up. How are people actually getting coverage? Another is to look at competition. One of the big promises of the Affordable Care Act was to create a more competitive health insurance market, one where it was easy to shop for coverage. President Obama used to talk about how he wanted it to be like an Expedia for health insurance. I think we've since learned it is a little harder to shop for health insurance than it is for a plane ticket. Building healthcare.gov was obviously a bit of a challenge for the Obama administration, but this was kind of one of the promises that the ACA made. And right now you're hearing a lot about examples of ways Obamacare is not delivering on this promise. I wanted to show this map because it's one that's coming up a lot, really just in the past week of the Affordable Care Act. And this is one that Margot Singer-Katz of the New York Times made. Lately, Republican legislators have been talking a lot about Iowa. Iowa is at risk of having a large part of its state with no Obamacare insurers in 2018. And this kept coming up again and again. On Thursday, when they passed the American Health Care Act, they kept saying we have to do this because of places like Iowa, where this large kind of pinker area of the state, it is served by one health insurance company in 2018 right now, an insurance company called Medica. 2 other carriers used to work there, but they've pulled out in the past few weeks. Medica put out a statement last week saying they might leave too. That would leave 94 of Iowa's 99 counties without any Obamacare insurers. So this has been coming up a lot in the debate. There's an area of Tennessee, 16 counties there, that also have no insurance companies signed up to sell. So that's the story from the non-competitive markets. And then you have this map that looks at the national picture. And again, it's one that California really seems to stand out in. You'll see that there's these red areas that are the areas in 2017 with just 1 Obamacare insurer. The green areas are the ones with 5, which are pretty rare at this point. But a number of them are out here in California. There are no counties in California with just 1 Obamacare option. You'll see none of the red here. And again, that's another way you can measure the Affordable Care Act, is it giving people that choice that was promised when it was written. In a lot of places, honestly, the answer is no. It has struggled to attract Obamacare carriers. Here in California, the answer has been yes. So what is going on with you guys? I'm sure a lot of people in this room have had a lot of roles in this, have played some kind of part. I think some of it does have to do with geography. A large state is appealing to insurance companies, right? There are some smaller states that really wanted Obamacare to work, that liked it, that have struggled to attract insurance companies. One that comes to mind is Connecticut, which is a state that built its own marketplace, did really aggressive outreach. They only have 2 plans signed up to sell coverage next year. And we just found out this morning, one of them is requesting a 35% rate hike in 2018. So, wanting it to work is not enough. You also need some geographic conditions. But I think that there are certain policy decisions California has made that really help the state out a lot. These are 2 I wanted to highlight. California is one of 6 states that participated in the early Medicaid expansion. So this was before 2014 when it actually started. States could raise their hand and say, we want to spend some of our money to start the Medicaid expansion early, to get the ball rolling, to get people signed up. Most states said, I do not want to raise my hand to spend more money because my state budget is very tight. But California was one of the 6 states that signed up for that. And I think that actually, in a kind of surprising way, helps out the marketplace. There is a growing body of research suggesting that states that expand Medicaid actually have more robust marketplaces. The thinking here is that when you have Medicaid expansion, you're pulling out some of the lower income sick enrollees, putting them on a public program, and that's lowering premiums for everyone else. There is a researcher at Johns Hopkins University, Aditi Sen, who she has found that states with Medicaid expansion have premiums that are 7% lower than states that do not expand Medicaid, which is a pretty significant difference. And then one other way California has always stood out to me is the state's active purchaser model, which again is very different from the vast majority of the states. Most states say, if you want to sell insurance on our exchange, that's fine, hit all the requirements, and you're welcome to sell here. This is how healthcare.gov works, which covers about 2/3 of the country right now, and how a good number of state-based marketplaces work. California has always been different in that it decided to do an active purchaser model, where you don't just have to check all the boxes, you actually have to be chosen to sell in the marketplace. And that really helps guarantee better plans for the consumers. And it really creates a more competitive environment. And one of the things I think that stands out a little bit about the state. So that's where we are now. The big question, which deserves to be this big at this point, is what is next? And it is very, very hard to predict. I was doing a planning call with some of the folks at the foundation earlier this week. I think this was Monday, I think it was Tuesday. And I said, well, I don't think they're going to get the votes. I don't think they're going to get there this week. And then Thursday, of course, as has been true many times since 2016, the predictions that we had did not really pan out. So I'm going to talk a little bit about kind of what happens after this. California is one of the states that has really participated most aggressively in the Affordable Care Act. What happens in an era of Obamacare repeal and replace? So just to give you a little bit of thinking of where we are now, as I'm sure everyone in this room knows, the House passed their Obamacare repeal and replace bill on Thursday, the American Health Care Act. And this was really a struggle for them. They had been trying to collect the votes for months now. They were supposed to have this vote back in March, in late March, and it was ended at the last minute. And Paul Ryan delivered this press conference where he went on TV and said, Obamacare is now the law of the land. And it seemed like, the fellow healthcare reporters and I, could go out to happy hour and take a little bit of a break because they were kind of calling this off for a little bit. But they kept working on it, kept amending it, kept making changes. And those changes finally got it through the House on Thursday. So this was a big step. It was a step I was not expecting a week ago, but they got there. And so it's definitely a big accomplishment, but there are still a lot of steps left in this process. And I just wanted to outline them right here. This is kind of the more boring version of the Schoolhouse Rock, how a bill becomes a law. So it's a little more complex than the dancing bill has told us. So the Senate is planning to write its own health care bill. It is not going to take up the American Health Care Act, which was a bit of a surprise when we learned that on Thursday. They basically said, we have a lot of problems. We want to start from a different place. And what you've seen happen in just the past 5 days is there are 2 committees that have started up on the Senate, one being run by leadership, one that includes a few more moderates like Senator Collins from Maine. Both of them are now working on coming up with a health care proposal. So that is just at the very beginning phases. The group that's being run by leadership is meeting on Tuesday or tomorrow, and that's kind of where things are expected to kick off. So first they have to write a bill, which, as many of you who work in legislation I'm sure know, will be a decently lengthy process. Then it has to go through something what we in DC call a bird bath, which is named for former Senator Byrd and has to do with the weird rules that they want to use to pass this bill. So one of the important things to know as you follow the American Health Care Act is they're trying to move it through a process called reconciliation, which is a process the Senate has to move budget bills with only a simple majority. This is easier to move things through the Senate in one way because you only need 50 votes, and you can certainly expect Republicans are not going to get Democrats to join them on this bill to get them to the 60 votes they would need to overcome a filibuster for most types of legislation. But through this special process called reconciliation, they can move something with 50 votes, meaning that with their 52-member caucus, they can still lose 2 members and move it through the Senate. In that case, Vice President Pence would come in and be the deciding vote. But here's the catch with the Byrd rule. Here's the catch with why it is not always an easy way to do legislation. Anything they work on has to relate to the federal budget. That is the requirement for kind of like using the special option, is you can only move certain things. And the bird bath is the name we use in DC for the process where the Senate parliamentarian goes through whatever bill comes up, line by line, and says, is that about the budget or is that about something else? And we're actually expecting this to be a pretty tricky process for Senate Republicans because there's a lot of things that they seem to want to do that seem to be much more about regulating the insurance industry than they are about the federal budget. I'll give you one particular example that has stood out to me. One thing that Senate Republicans seem to want to do through this process is change how much insurance companies in the individual market can charge the oldest enrollees and the youngest enrollees. Right now, under the Affordable Care Act, the oldest enrollees can only be charged 3 times as much as the youngest. The senators would like to expand that to 5 to 1, meaning that the oldest enrollees could face premiums 5 times as much as the youngest enrollees. Now, that might be a tricky one to get by the Senate parliamentarian, because she might look at that and say, that's about regulating the insurance industry. That is not about the federal budget. The Senate aides are going to have to go back and forth and say, well, here's our case for why it has to relate to the budget. And then eventually it'll come down to one woman who's going to have a very stressful month in the next few months who has to make all these decisions. So that's just step 2, just getting through that process. So let's say they move through that. The Senate bill would then have to pass through the chamber. Like I said, they could only lose 2 votes, and so they really have to get the vast majority of their caucus on board with this. If it passes, you'd have a conference committee that meets to merge the House bill and the Senate bill, put them together in one bill. That gets sent back to both the chambers, where it once again has to pass a second time, and then it finally goes to the president's desk to be signed. So these are kind of all the steps that have to happen before we end up with something. And it helps to keep in context that we did have a big moment on Thursday, but there is still a lot of work standing in front of Republicans. And there are 2 big issues that I think I'm going to be watching a lot in the Senate that I think are really going to come up a lot that these working groups are going to think about. And we're going to dig into both of them a little bit more in depth. One is, are the cuts to Medicaid just too large? This is something that a lot of senators have already voiced concern about, particularly senators from states that have expanded Medicaid, places like Kentucky and Ohio that have a lot of people signed up for these programs. Senator Rob Portman from Ohio, he put out a statement, within minutes of the bill moving through the House, saying, I can't support this bill because it cuts too much from Medicaid. So that's going to be a big issue. Are these cuts too large? Does the Senate want to write a bill that has a more generous Medicaid funding portion? The second, are the premium subsidies too small? This is another issue that's really dividing senators and an issue that they are worried about. This is especially true for Lisa Murkowski, the senator from Alaska, because insurance is really expensive in Alaska because you need to pay high salaries to get doctors to Alaska, and you need things like helicopters to deliver healthcare in Alaska. The way that the way the American Health Care Act subsidies are structured, it would be a huge premium increase for states where health insurance is just expensive because of the place that it is. So that's something that someone like her is going to be watching very carefully. So let's dig into these a little bit more. So this is the Medicaid portion of the American Health Care Act. And it's something that almost got lost a little bit in the coverage of the past few days as we all talked about the amendments, which certainly matter, and the essential health benefits and pre-existing conditions. One of the things that did not change at all through this whole process was that the American Health Care Act cuts $880 billion from the Medicaid program over 10 years. You can see that the cuts really ramp up over time. They get much bigger between 2019 and 2020, because that's when the Medicaid expansion essentially stops signing people up. And if you fall off the program, you can't come back on it. So this is just a really significant cut. And it's one that we're going to see a lot of debate about in the Senate. And it's actually one that makes it has proved a surprising challenge to the Republicans. I talked to one legislator, Phil Rowe from Tennessee, who said, he thought the easy part would be cutting Medicaid, because Medicaid often doesn't have as strong of a political constituency. He said something that has surprised him about this process when we were doing this interview, was that cutting Medicaid has proved actually much, much harder than he expected. So this is going to be a real key area of debate, is are the Republicans okay with cuts this large when they're hearing from hospitals and doctors and advocacy groups all over the country who are fighting tooth and nail against these kind of cuts. Then you have the private insurance side, the tax credits for people who buy on the marketplace. And so I want to show you, this map might look a little bit overwhelming, but I will help explain it. So this is a map that shows how much premiums out of pocket people would pay under the American Health Care Act. And this is specifically for a 40-year-old who earns $30,000. And you can see everywhere the premiums would go up. This is because the American Health Care Act, it just has less generous subsidies than the current law does. There's just less money spent on subsidizing the individual market. But one of the things that's quite different is these subsidies in the Republican bill, they are not responsive to the local cost of health insurance. It doesn't matter that you live in Alaska, for example, and have really high premiums, or that, let's say you live in New York City, which one of the weird things about New York City is because it's an urban environment, it's actually much cheaper health insurance. And you see a microcosm of this in California, where the people in Northern California would actually face higher premium increases under the American Health Care Act than those in Southern. And that only reflects the fact health insurance is more expensive in this area. So I thought this might be another helpful way to display this data. I pulled information from that map about the out-of-pocket premiums for a 40-year-old here in San Francisco under current law and under the Republican plan. So this is after your subsidies, how much they actually have to pull out of their bank account for an entire year to cover their premiums. And one of the things you'll notice for the lower income folks, someone who earns $20,000, this is going to be very hard. This is an increase of over $2,000 in expected spending on premiums. It's just really significant. For someone who earns $30,000, it's an increase, not as much. For someone who earns $40,000, they are actually getting more help under the Affordable Care Act. And one of the things you'll notice that's quite different about these two columns is under the Republican plan, everyone's getting the exact same help, right? It's $3,280. I think these are 2020 figures, regardless of how much they earn. This is true under the Republican plan up to $75,000. You could earn $15,000, you could earn $50,000, you're getting the exact same help. The Affordable Care Act is very different. The Affordable Care Act gives more help to the people who have the lowest incomes. And that's really one of the key things to keep in mind about how these are different. There are people who would benefit from this. If you are someone who's earning $60,000, you're all of a sudden getting help that you weren't otherwise. But there are certainly people who lose, and they tend to be the lower income people who are using the ACA programs. So this is kind of where I'm going to wrap up a little bit, is I talked about California's role in the Affordable Care Act. What is California's role in the debate around the American Health Care Act? So I kind of think of two things that come to mind. One is California strikes me as the state that, again, as I said earlier, is an example of what is working in the Affordable Care Act. There are going to be a lot of Republican legislators talking about Iowa. They are going to show that map that I showed you. California is really the best counterexample I think the defenders of the Affordable Care Act have to say, no, this is actually working pretty well in some places. We have high coverage, high competition. We think that this law is really delivering some good things in our country. The second thing, which I'm more curious about to see how it develops, I don't know, which is why I left a question mark on there, is does California become a place where you have essentially anti-HCA lawmaking? Is there stuff you all are doing either through regulations or bills that tries to keep the Affordable Care Act in place in California? Because you all, it seems pretty clear, want to keep it standing. So things I think about are mandating coverage for birth control, for example, making sure that that part of the ACA sticks around even if the Affordable Care Act were to go away, mandating coverage for the essential health care benefits. The Republican plan right now includes the possibility to waive out of those. Maybe California is the kind of state that would consider mandating at a state level coverage for those benefits. One of the hardest ones, I think, is actually keeping the financial support of the Affordable Care Act in place. I know that if the American Health Care Act became law, California would lose a lot of money, both the subsidies for the private marketplace and the Medi-Cal expansion. Is California going to explore possibly funding some of that at the state level? I'm sure it is a very hard task. We're talking about billions of dollars, but I think if there's any state that's even going to explore it, California kind of feels like one of the prime candidates to look at. Is this something we could take on the state level? So that is where I'm going to end, and I'm going to join Scott here for some questions.
All right. All right.
Okay.
So last week, of course, Republicans did a nice victory dance at the White House with the president. There was a lot of promises of tattooing the legislators with their vote on this bill. But then we hear hours later, as you said, that the Senate isn't even going to really take it up, that they're going to start all over again. So how much attention should we be giving to the American Health Care Act, and what do we learn from the fact that it did pass? I mean, what does it say about what the final bill might look like if they can pass something based on what they've already passed, even if it won't become law as it is now?
So I think there's actually a lot we can learn from the House vote, even if that is not the bill that becomes law, because it shows the type of proposal the House is willing to pass. And like I was saying earlier, whatever moves through the Senate, it's going to have to go to a conference committee, it's going to have to go back to the House and the Senate. So we kind of learned something about the boundaries of what is acceptable to the House and what isn't. One of the things that I think was a really key boundary we learned about is it doesn't seem like the House is willing to pass a bill that requires the same protections for pre-existing conditions that the Affordable Care Act currently requires. And this mostly has to do with this group of more conservative legislators, the Freedom Caucus, who essentially said, this is our demand for getting us on board. We want these waivers out of the community rating provision, or else we're not going to play ball.
Is that a money thing? Like a government subsidy, like a budget thing?
It's more of a philosophy thing for them, where they don't think the insurance, they think the insurance industry is overregulated and that people should have more access to smaller, less expensive health insurance plans. And one of the ways that you make the premiums cheaper on the individual market is you don't require insurance companies to cover sicker people. Now, obviously, there are a lot of flaws to that policy, because then where do the people who are sicker go? And then you get into the discussion about high-risk pools. But it really seems to be more of a philosophy of the Freedom Caucus, and it's about money too. It's a lot less expensive to fund those kind of health insurance plans.
So when the Congressional Budget Office scored the bill that never got to the floor last month, it showed that up to, I think, 24 million Americans could ultimately lose health insurance. The bill that passed last week has not been scored. Is it going to be?
That is the presumption, but like I said, predictions are not always great in DC right now. But yes, we are expecting the CBO to come out with a score of the American Health Care Act, likely sometime this week or next week. And it's a little hard to know what that score is going to look like. I think the Medicaid side will remain very similar, because Medicaid essentially did not change throughout the debate over the American Health Care Act. The question is what they think about the private insurance. They added in these waivers, which if states applied for those would probably lead to even less coverage. They added in a bit more funding for high-risk pools. So we're going to kind of find out, how many states does CBO expect to apply for a waiver? This is a hard bill for CBO to score, because they have to make an educated guess at how states will react to this bill versus the last version, which was just everyone got the exact same thing.
Yeah. The map you showed was fascinating. One of the maps that showed the percentage of people, the drop, I guess, in the uninsured, and among the best states were Kentucky, I think, and West Virginia, two solidly anti-Obama, pro-Trump states. California also one of those states. Is that having? I mean, of course, Mitch McConnell is from Kentucky. Is that having any impact? What's happening on the ground for all the rhetoric about repeal, get rid of Obamacare, it's failing, it's collapsing, all that rhetoric. Is there any indication that there is pressure on those senators in particular now to take into account that it is working in their state, apparently?
Not yet. So, I did some reporting out of Kentucky at the end of last year, because I was curious about this question, that Kentucky, has one of the biggest drops in uninsured rates in the entire country, has had a lot of people sign up for Medicaid expansion, and yet it went overwhelmingly for President Trump, and I kind of understand that connection. And it seems like when Democrats passed the Affordable Care Act, they had an expectation that once people got coverage, it would become popular, and people would start to like it, and they'd say, oh, actually, this Obamacare thing is pretty good. Tons of people got coverage in Kentucky, but that theory did not prove true at all. I think the voters I talked to there who voted for Trump and used Obamacare, they really just thought about the problems with their coverage. They thought about my deductible is too high or my premium is too high, and many of them were very happy to have coverage. They'd gotten coverage for the first time, but they also had these gripes about it. And they had listened to President Trump during the debates, where he said, "I'm going to cover everybody, and it's going to be great health care." And they believed those promises. I think the people who are actually getting more worried are the senators who represent those states, who are starting to understand what it would mean to make those cuts. Particularly, I actually see it a lot in Ohio. It seems like the Ohio delegation is very nervous about what would happen if they cut this.
And there's of course the mantra for Republicans for years has been to get rid of Obamacare, to erase it, repeal it. replace it, don't fix it, just get rid of it. It's imploding. All those things. But I'm wondering, to what extent, just taking a step back, the extent to which the Affordable Care Act has had an impact on our healthcare system that can't be erased by legislation. The ways in which healthcare delivery systems are thinking about care, the incentives that are built into the ACA for more efficient care and better outcomes. Like, to what extent is that now embedded in our system?
So I think it's been really interesting that the delivery system side of the Affordable Care Act, which is this whole huge other bill. I remember, when I talked to former Medicare Administrator Don Berwick, he said if that part had passed on its own, it would have been considered a massive Medicare reform, but it kind of got overshadowed by the fact it was attached to a big coverage expansion. No one's really talking about rolling that back. No one's saying we should end the Accountable Care Organization program. No one's saying we should reverse the readmission penalties. Those parts don't really seem up for debate. So I think that part is definitely very entrenched, very much moving forward, regardless of the transition.
Does that mean it's working?
I think there are places that are working, places that aren't, but it's definitely an experiment that Washington wants to keep going and see what are the best programs. I think one other thing that has changed that we've only learned in the past few weeks is how people think about pre-existing conditions. There is just this kind of disbelief at the idea we would go back to a market where someone could be charged more because they were sicker, and that's really
or denied
or denied coverage. That's really pushed back really strongly against the Republicans' efforts. So I think that I was lecturing at a college class about a year ago, and I used the term pre-existing condition, and one of the college students said well, what's that? And I felt like such an old person being well, back in my day, when I started covering healthcare, you could be charged more. And it's only been 4 years, but people have gotten very used to expecting that is not a practice in the insurance market.
Yeah. So California, of course, as you said, has been all in on the Affordable Care Act, and it seems to be working. The marketplace is fairly stable. We've covered huge numbers of people. And yet, there is now a robust conversation happening about single-payer healthcare. Something Bernie Sanders has talked about. Our Lieutenant Governor, Gavin Newsom, who's now running for governor next year, has embraced it. I've been to town hall meetings with Democrats and Republicans, and that's who shows up, is people who are supporting single payer. You're from Canada.
I am.
Which is often held up.
I survived a single payer system. And
well, tell us, because we had legislators who just came back from Canada to see how terrific it was. What should they have seen that they maybe didn't?
So I only lived in Canada till I was 12, so I'm not a great representative of that. And I have only positive memories of the healthcare system, but they're also a little bit old. I think actually the one that I am more familiar with is Vermont's recent single-payer effort, which they are the state that arguably has gotten the furthest on trying to pursue a single-payer system, and I covered that effort pretty closely in 2013 and 2014. And I think you're right. The desire for single-payer and the activism around single-payer has really been energized by the repeal and replace movement. You even saw, a conservative like Charles Krautheimer, saying he thinks that we're speeding towards that system faster at this point if we repeal the Affordable Care Act. I think the challenge always comes down to financing, and this is what Vermont ran into. This is why Vermont ultimately didn't pursue single payer, even though they had done kind of the amazing task of getting not just the legislature and the governor on board, but they got their hospitals on board with this, which is usually, a pretty big hurdle. But they just found they did not feel comfortable pushing the size of tax increases that they would have had to do in order to finance this. And it's completely true, those tax increases would have been offset by people not paying insurance premiums anymore. But those headline figures, they did not want to move forward with. And I think this speaks to kind of a particularly unique difficulty of doing something like Canada's system in the US. Is one of the reasons single payer works in the US isn't necessarily about the system itself, it's about the prices. It's the fact that they pay much, much lower prices for nearly everything. So we did not go with a single payer system in the 1940s and 50s when a lot of countries kind of figured out their modern insurance systems. And one of the side effects of that is we let the prices of healthcare get really, really, really just absurdly high. I've written stories about people who go to the ER and get a Band-Aid on their finger and then they're charged $629 later and they have no recourse. They are required to pay that bill. One of the things that I think makes single payer so hard, isn't because it's too much like Canada. It's because our healthcare prices are so high that a single payer system in the United States would be much, much, much more expensive than a single payer system in Canada, unless we are willing to say we're going to slash our prices 50%. And that is a very difficult discussion to have about doctors' salaries and employment in the healthcare sector and overall economic growth. So that seems like the real obstacle to single payer is just our prices have gotten so high. It's almost like a chicken and egg problem. We didn't set up single payer, so our prices got really high, and now it's much harder to set up a single payer system.
And is that more true for a state trying to do it than if the nation, let's say we had done Medicare for all way back, back in 2010,
Right.
would the economics of that be different?
I think it's a little easier when you're, an entire country doing it. One of the issues Vermont ran into, for example, is they share a lot of borders. They have people who commute across the border. How do you deal with those kind of problems? But I don't think it's impossible for a state to do it. One of the things we've really seen with the Affordable Care Act is that it was really a state innovation in Massachusetts that was the model for the national healthcare law. And I could see single payer working the same way. And that's how, when I would interview former Governor Shumlin in Vermont, he would say they really want to be the Massachusetts of single payer. They want to be the ones to show that this can work. So I think you almost need it to happen in a state in the US before it could happen nationally. Because it's easier to see it happening somewhere like here than to see it happening in Washington.
So one of the other charts you showed, or maps, in the number of insurers per county, and just like, why does it matter per county? Is that just for?
That's just the easiest region to subdivide by.
Okay.
So
one of the things Republicans often talk about is why can't we sell insurance across state lines? Mm-hmm. Is there a lot of discussion about that now? I didn't hear much about it. Was that part of the American Health Care Act? And what's the problem with that theory?
So it is not a part of the American Health Care Act, and it actually goes back to that bird rule and bird bath thing I was talking about earlier, where it's just impossible to make the case that allowing insurance sales across state line is a budget issue. So they didn't even try and put it in there. I'm sure you guys heard Paul Ryan talking about the three prongs or the three buckets or whatever analogy was being used. They see that as a separate bill. They would move separately from the American Health Care Act because it needs 60 votes. So that's kind of set aside. In terms of a policy idea, so it's pretty simple. The idea is that insurance companies should be allowed to sell coverage, in any state they want. So insurance companies that's based in Alabama, for example, could sell policies to people who live here in California, even though I'm sure California has more benefit mandates than Alabama likely does. I think the challenge is we've seen some states open up their marketplaces for across state line sales, and there just isn't take-up. Sabrina Corlett, who's a researcher at Georgetown, has done some work on this, where she went to these places, and it turns out it's just really hard to build a health insurance plan in California if you live in Alabama, because you have to go meet with all the health insurance, all the hospital executives and the doctors, and you have to set up a network, and you have to serve your customers in California.
What if you live in Arizona?
If you live in Arizona, that might be a little bit easier, but still breaking into those markets can be a little bit challenging, and states really don't like it. If you talk to conservative state insurance regulators, they absolutely do not want this plan to pass. Even, they're members of the Republican Party. They say it should really be a state's right to determine what health insurance looks like. We in California set the rules we do. In Alabama, you can set your rules, but it's really up to us, as a state to decide what kind of health insurance is and isn't acceptable in a state.
Yeah. I know I'm supposed to be watching the time, but I don't know where the timekeeper is. There he is. We good? We're good? Okay, good. And we are going to give you all a chance to ask questions as well. We'll have some people with microphones, so be thinking of what you want to ask Sarah. One of the favorite policy points of Paul Ryan is the block grant notion, that you just cap the amount of money, you give it to the states, and you say you do whatever you want with it. How would that affect a state like California?
Very significantly, because it's very similar to the rest of the healthcare bill. Any state that has gained a lot, or has high enrollment in healthcare programs, has a lot to lose from these kind of proposals. And the block granting part of the HCA hasn't gotten as much attention. We call it an Obamacare repeal bill, when it's actually a complete Medicaid overhaul bill as well. That block granting is not related to the Medicaid expansion. in any specific way. You could just end the Medicaid expansion and leave it at that and say you've repealed Obamacare. But the Republican bill takes it a step forward with these. So I guess these ones are technically per capita caps. So essentially it's a per person block grant. You get a certain amount of money for each person signed up in your Medicaid program and less restrictions on how that money is spent. And there's a pretty good analogy that we did something quite similar in the welfare program about 20 years ago and really saw the states spending money on all sorts of programs that the bulk of the benefits no longer went to actually cash assistance for the poor. I recently listened to, there's a wonderful podcast series from Marketplace called The Uncertain Hour that I highly recommend as kind of a preview of what looks like, what happens when you block grant a program. They really looked at what happened when welfare was block granted. And that was really instructive for me to think about what might happen to Medicaid if you really gave people a set amount for each person in their Medicaid program and were a lot less kind of restrictive in what states could do with that money. So they might start spending it on wellness programs and spending it on other things that, enhance the health of the population, but aren't actually, covering doctor visits and medical bills. That's at least the experience we've had with the welfare reform, we went through about 20 years ago.
Yeah. California, as you said, is often held up as an example of success and what can happen if a state decides it wants to embrace the Affordable Care Act. And of course, we have 14 Republicans representing California in Congress. They all voted for the American Health Care Act. And I'm just wondering, I'm not sure, what am I wondering? Do they believe, they represent a state where this is working, and I mean, it's not perfect,
right.
But in a lot of the different metrics, it's working. Do they just, they just don't truly believe it, or is it more politics than policy? Maybe that's an obvious question.
Yeah, no, it's a hard one to deduce, particularly from states. And you have a few examples of this, of legislators from states that serve more conservative districts in liberal states that, where the law seems to be working decently well. And I think there was a ton of, pressure from leadership to get this bill through Congress. One of the things I think I did not understand this dynamic was so strong until this past week is nobody wants to be the person. A lot of people aren't huge fans of this bill on the Republican side. A lot of them will happily admit to reporters, this is not the bill we wanted, but it's something. They prefer to vote for a bill that they're not super excited about than to be the one who stopped Obamacare and repeal and replace, than to be the person who stood in the way of this thing they have promised for 6 years. And my colleague Ezra Klein at the Post, or not at the Post, we used to be at the Post, at Vox, he kind of termed this healthcare hot potato, where no one wants to be the one kind of left holding the bag, saying you're the reason this bill didn't pass. And I think there's a lot of that dynamic going on with legislators from California, for example, that, a lot of different groups have gone through this and you've seen them come on board. Like the Freedom Caucus after the last round of negotiations, they were the reason it didn't pass. So they said, okay, we'll get on board. And then it was the moderates, and then they got on board. So I think there's a very strong force, and I think it's going to play out in the Senate, of not wanting to be singled out as what stood in the way of achieving this really core Republican policy
project. If the Senate wanted to also not be the ones that stopped reform or repeal, whatever you want to call it, what could they do? What might they do that would basically allow the current system, maybe fix what's wrong with what's happening, with what's wrong with the Affordable Care Act, which is what Democrats would like to do, but call it something else and call it a day?
Yeah, so I think if you wanted, the biggest challenge I think the Affordable Care Act faces right now is competition in the marketplaces and this risk of some areas going without an insurer. The ACA can get along all right with just one insurance company because the premiums are subsidized for low-income Americans. They don't actually feel the big rate increases. It is quite expensive on the back end for the federal government, but if your goal is at least getting people covered, and so you're starting to see this year a pretty serious risk of places that have zero Obamacare insurance companies. And that would mean people would have tax credits, but they would have nowhere to spend them. So, someone, let's say who earns $20,000 and is getting a pretty hefty tax credit, let's say in Tennessee, an area around Knoxville, which has no insurer signed up in 2018, they would have to pay full price. They would not be able to get their tax credit outside the marketplace. So I think if you wanted to really stabilize the Affordable Care Act, deal with what's wrong in it, you would really look at solutions to get more insurance companies in those marketplaces. The thing is, even the solutions to that are polarized. Republicans have one way they want to do it, Democrats have another way that they want to do it, and it's hard to see the Senate or the House like working together on a fix to the healthcare law right now.
You mentioned Susan Collins being on one of those committees in the Senate, and she co-authored a bill that would basically allow states to choose for themselves if they want to continue being a part of the healthcare exchange and so on. What are the prospects for that?
Not great right now. So this is a bill written by Senator Collins from Maine and Senator Cassidy from Louisiana. And I found it a really interesting idea where basically, and I've talked to Senator Cassidy about this a lot, and he actually brings up California a lot when he talks about this bill. He says, if California likes the Affordable Care Act, great. You know what, they should keep the Affordable Care Act, that's fine for them. But in Louisiana, we don't want the Affordable Care Act. We want to do something different. So the bill they co-authored would essentially have different choices for different states. And I think the challenge with that is it's a compromise bill at a moment no one wants compromise. Republicans don't seem to want to sign on board to let some states keep the Affordable Care Act. They really want to get rid of it. And Senator Cassidy, he's been quite critical of that approach. He says, if we're going to criticize the Democrats for saying everyone has to have Obamacare, it's going to be hypocritical to say, well, everyone has to have our plan too. But right now, it doesn't seem to be gaining much traction. There's much more energy behind a national plan for all 50 states.
Are there things, you mentioned that the senator from Louisiana talks about California. Are there things that California has done, for better or worse, that are the subject of conversation back there, especially among Republicans? Because Democrats, obviously have embraced it. But, are there things that they find interesting or useful or productive about what California has done, or they just really just want to get rid of the whole thing?
I think they just want to get rid of the whole thing. I've talked to a lot of legislators about the Affordable Care Act and about the only time California's come up and are in those conversations I've had with Senator Cassidy. So he's kind of the exception in that he's willing to say, yeah, it seems to be working fine in California, and that's okay if they want to continue that system. But in general, really on both sides, and I think this has actually been a weak point for Democrats who have been very much in a defensive crouch and not willing to talk about the problems with the Affordable Care Act because it kind of opens the law up to more attack. And I think that's, on both sides, there's not really a willingness to say, well, here's what the other side has gotten right. And I think that kind of, stops the debate a little bit. And you really don't see that recognition from either side of, what the other side is saying about the healthcare law.
Yeah. So we don't know what's going to come out of the Senate, much less what's going to come out of Congress or the president will sign. What can the administration do to accelerate the decline of Obamacare? And is that politically, feasible, smart?
It is everything they could do to accelerate the decline. They are probably doing right now. So the things they are doing are, and I have a story on Vox today of, talking to insurance companies who, a few of them have told me that they are charging higher premiums in 2018 specifically because of things that the Trump administration is doing. So the things they are doing are they are not being clear if they're going to enforce the individual mandate. That's a huge one for health insurance companies because if the mandate isn't forced, they are nervous that healthy people are not going to sign up for coverage. The other key thing is whether or not they're going to pay these Obamacare subsidies known as cost sharing reduction. Subsidies which are not the ones that go to premiums. These are subsidies for copays, subsidies for deductibles that are given to the lowest income Obamacare enrollees. There is currently a lawsuit pending against those subsidies, and the Trump administration has been very, very cagey. I've described it as aggressively ambiguous about whether it'll continue to pay those. And all this uncertainty, it basically pushes either insurance companies to leave the marketplace or to charge higher rates because whenever you talk to an actuary at an insurance company, they'll tell you uncertainty is very expensive and you price for the worst case scenario. So when you look at Iowa, for example, they had, in 1 week in April, 2 insurance companies pulled out of Iowa, the local Blue Cross plan and Aetna, and both of them cited the uncertainty about the future of the healthcare law when they were explaining why they were leaving. So I used to think, this would be a really bad strategy for the administration to accelerate the demise of the marketplaces because people tend to blame the administration in power for whatever problems they're having. But there's no evidence I've seen yet that they want to stabilize the marketplaces, and a decent amount of evidence that they are okay with destabilizing them.
Yeah. Well, we have a lot of smart people here who I'm sure want to ask questions. We're the folks with the microphones are in the back. So if you just raise your hand and we will come to you with a microphone. There's somebody right here. Maybe we can start, and then is there somebody else? Maybe right here on the aisle. I think you're first. Yeah. And if you could just say, if you feel comfortable saying your name and what organization you're with.
This is Lucy Johns. I am Vice Chair of the Board of Directors of Direct Trust, which is a national nonprofit in the business of establishing trust for health information exchange. My question is completely unrelated to that.
That's okay.
Nancy Pelosi made a very dramatic statement about tattooing for the purposes of campaigning in 2018. Given the meat grinder that we're observing now, do you see any people actually feeling the effects of what might happen by 2018? I don't think they're going to. So the argument for Democrats in 2018 is going to be more ideological, from my point of view, than actual experience of people discovering that the Republican promises about the best health care ever are not true. So could you comment about 2018, please?
Yeah, so I do think you're right in the sense, I don't think if the American Health Care Act passes or some Republican bill passes, it'll probably not take effect in 2018. But what I was just talking about, this kind of destabilization of the marketplaces, people being stuck in areas where they can't use their tax credits, that will play out next year. That'll start January 1st, 2018. So let's say Iowa does end up with no Obamacare carriers in 94 counties. Like, that change is real for, I think it's about 72,000 Iowans who use those marketplaces. That change will be real on January 1st. So I think that's where you'll see the most shifting, in terms of people feeling this in their everyday lives. But I think a lot of it is not necessarily about people feeling it in their everyday lives, because Obamacare enrollees are still a relatively small part of the population. A lot of it is talking about, a lot of things the Democrats have already been talking about pre-existing conditions and discriminating against those people and reinstating lifetime limits. Those will be things that I think will be emotionally and politically appealing to voters, even if they're not feeling the effects themselves.
Well, and I think an analogy to that is 2010.
Yeah.
Congress passed Obamacare, the president signed it, really hadn't gone into effect yet, and yet Democrats got creamed that year in the off-year elections, and so I think Democrats are hoping that happens this time around. We'll see. Yes?
Hi, thank you. My name is Brian Sale. I'm the Deputy Director at California's Mental Health Services Oversight and Accountability Commission. But I have kind of a wonky question with a political follow-up on it. You touched on pre-existing conditions a little bit. I understand in the bill there is a waiver process regarding essential coverages. I wonder if you could talk a little bit more about the essential coverage waiver process and how that relates to employers and the potential for employer choice. And then the political part is, what are you hearing, or what are your senses on the survivability of those components of the bill when we go over to the Senate side?
Right. So that's a great question. So the waiver provision was just added in about 2 weeks ago, and it basically allows states to apply for a waiver from the essential health benefits. This is a package of 10 medical services that all insurance companies are required to cover. It includes things like hospitalizations, mental health services, prescription drugs, maternity care. Some of those benefits are ones that the individual policies tended to not cover before a mandate because they're very expensive. One example is that in the individual market before the Affordable Care Act, only 12% of plans would cover maternity benefits. Prescription drugs and mental health services were other ones that were often not included in the package. So what the Republican plan would do is it would let states who want to apply for a waiver to say, we do not want that benefit. We want to choose in our state what insurance companies are mandated to cover and what they aren't mandated to cover. So that is basically how the waiver process works. There's a really interesting story by Chad Terhune, who works for Kaiser Health and who's here in California, he wrote today about why he wrote today about the possibility of even states like California possibly applying for those waivers because the subsidies would get so small. Those smaller plans might be the only thing that's affordable, and that kind of presents a liberal state a dilemma. Do you keep the mandate and you keep premiums a little bit higher because you're mandating these benefits, or do you apply for a waiver to make them more affordable with the tax credits people are getting? So I think, if it were to pass, I am very curious about what states would do with that waiver process. This also relates to employer-sponsored benefits and lifetime limits in a very confusing, roundabout way that I don't think Republicans even understood until the Wall Street Journal ran an article about it on Wednesday morning last week. So right now, the essential health benefits, that is the package that the lifetime limits applies to. So basically, it says you can't lifetime limit anything in the essential health benefit package. So you can't lifetime limit hospital visits or prescription drugs or mental health services. If it's in the essential health packages, you have to keep paying that no matter how much it costs. So if states are waiving out of the essential health benefits, they're saying we don't use that regulation in our state, they're essentially waiving out of the baseline for the lifetime limit. So once again, states could lifetime limit things. And the way it gets even more confusing is you only need one state to apply for a waiver for employers in any state to choose a new essential health benefits benchmark and say, we want the waiver state. We want to use that for our employer plan because of regulations drafted by the Obama administration that said employer plans can choose any state as their benchmark. Well, under Obamacare, it didn't matter much. The state benchmarks were very, very similar because you had this national regulation of what they had to look like. If the state benchmarks get very different, employer plans could basically pick the one they like the best, which could be the skimpiest, and say that's the one we want, and then they could lifetime limit those other categories that aren't included. So, and I think the fact it's even there, it really speaks to the very rushed, fast drafting of this bill. I don't think Republicans wanted to bring back lifetime limits. Paul Ryan has said repeatedly in interviews he doesn't want to bring back lifetime limits. So the fact this was there, I found also the exemption for legislators, that the amendment didn't apply to them. That was another thing that a lot of legislators didn't seem to know was there when I found it. I think a lot of this really speaks to the very rushed, fast drafting of this bill, that we keep finding things that Republicans didn't even know were in the bill that they wrote.
Other questions? Yes, in front. Oh, and then you're next. Sorry.
I should go in front of her.
Matthew Oswald. Sorry, we know each other. This is Andy Gaze from Health Tech Capital. One of the things that nobody has talked about is the impact on the economy. AARP came a couple of weeks ago and showed that 71% of Americans could not come up with $1,000 in cash in case of emergency. But we know for sure the cost will go up, the deductible are going to go up, and you're going to get taxed out. And the leading cause of bankruptcy in this country now is medical debt. Nobody seems to be calculating the impact of this bill in slowing down the economy to a halt. Can you comment on that?
Yes, I think there's definitely the issue of medical bankruptcy. I think medical bankruptcies they've fallen significantly under the Affordable Care Act because more people are getting coverage. I'd say the other thing that would be going on is employment in the health sector, which has grown very, very quickly under the Affordable Care Act. When more people have gotten health insurance, hospitals have had a lot less unpaid bills, and they've been hiring a lot more. One of the things, we actually have a story up on Vox today from one of my colleagues who covers economics, that you've already actually seen a bit of a slowing in healthcare hiring in 2017. We don't know if that's related to the healthcare bill or not. We're noticing it right now, and maybe it's a plateauing that would have happened otherwise. But there was a story just in the New York Times, I think on Sunday, looking at the fact the Affordable Care Act has kind of been a job engine. A lot of people have gotten coverage or have gotten employed because we have more healthcare spending. And for someone, for example, I think there's also a decent number of cases of people being well enough to work because they have the healthcare they need to be going to a job on a regular basis or not be facing medical bankruptcy. So I think there's definitely would be an economic impact, and part of it would manifest in the impact on enrollees, and part of it on the providers and the hospitals and the doctors that serve those people too.
Just sort of a tangential to that, this has been implemented, the ACA, at a time when the economy's been recovering, jobs are being created, growth maybe not as strong as a lot of people would like, but things have been getting better by and large in the aggregate. What happens if there's suddenly a downturn? I mean, what does that mean both to the ACA but also to the healthcare marketplace and so on?
Well, the marketplaces, I think they should be fine because they're written kind of responsive to income. Like they should be able to weather, ups and downs in terms of keeping people covered. I think this is something you really worry about. The idea of a blank grant or a per capita cap is one of the reasons Medicaid has traditionally had an open-ended funding, is it's kind of meant to be that safety net for when enrollment goes up, when enrollment goes down. With these per capita cap funding formulas, they're usually written a year or two in advance, saying, well, you had X number of people in Medi-Cal last year, so we're going to assume you have this many next year. If you get hit with some kind of economic downturn, your funding formula might not catch up with that for a year or two. So it really seems like the programs in the HCA would be less resilient to kind of economic ups and downs.
Yeah. Yes.
Matthew Holt, Health 2.0 and the Healthcare blog, and friend of Andy East. So this is a slightly more personal and political question here, Sarah.
Okay.
I want to really thank you for your sort of rewriting of Healthcare of Congressional 101. I would recommend you show that to the president, because I'm not sure he understands it. But the good news is, in order for the ACA to be repealed and changed, we have to have a Senate bill, and the Senate bill has to pass, and I think we can assume the president would pass it. Now, recently you got married.
I did.
You went on honeymoon.
Yes, I did.
And when you went on honeymoon, everyone thought they were going to pass the bill, but they didn't.
No.
Then you came back, and they did pass it.
Yes.
So can I suggest...
Are you asking if I'm to blame for this?
No, not exactly, but just to be on the safe side, can we encourage you and your husband to get divorced, get remarried, go on honeymoon again, we'll all crowdfund it, and just stay there until the Senate goes into recess for the summer? How about that?
I mean, that sounds delightful, but I don't know if my husband of 6 weeks is going to be on board with the divorce and remarriage. I will note that, Ezra Klein, my boss at Vox, he was on vacation for this bill. So we've decided they can't pass it if both of us are there. One of us has to be out of town for the conditions to be right.
Carrie.
Hi, I'm Carrie Feibel, KQED Health Editor. Welcome to California, Sarah. Can you explain, even before the Trump administration began, what Republicans in Congress were doing as far as the 3R payments to insurance companies? And is it a valid talking point from Democrats and other supporters of the Affordable Care Act to say, well, if all those had been funded properly, then there would be no problems in Kentucky, that the Affordable Care Act marketplaces would be working perfectly well? Is that valid?
Maybe just say for the
Yes.
benefit.
Yeah. So one of the important things that happened in 2014 in Congress, and I don't think we realized how important it was at the time, was Senate Republicans inserted a provision in the budget that said one of the stabilization programs for the Affordable Care Act had to be revenue neutral, meaning it could only pay out as much money as is taken in. This was the risk corridor program, which was meant to be a program to kind of make the Affordable Care Act more attractive to insurers. I actually like to think of it was like bowling with those bumpers in the alleys, where you could bump a little, you could lose a little money, you could make a little money, but you couldn't go in the gutter. You could only lose, I think, it was supposed to cap insurance companies' losses at 3%. And basically say, yeah, the market's risky, but you can't go in the gutter. You'll just lose a little bit of money. What happened was when the budget, and this is a budget that President Obama signed, so this is something that he signed off on, the budget said, well, you can only pay out as much money as you're taking in, and it turns out insurance companies lost a lot more money than they earned. So there was not enough money in the risk corridor program to offset all the losses. So all of a sudden, I think it was 12 to 16% of the payments that insurance companies were expecting actually got paid out. So I've talked to some small insurance companies who this was a huge deal for. They just did not have the reserves to stay in the market. I think this is a big part of the story of the co-op plans. Most of those have gone out of business at this point, and a lot of them said they just could not, they had priced for these payments, and once they didn't get them, they really did not have the reserves to stay in the market. So I think that's definitely the story with the small plans, and it's a reason why the marketplaces will be working better if those payments had been around. That being said, I don't think it really explains the large companies pulling out. Companies like United and Aetna that could weather that storm, that could survive those losses all right. they also left the marketplace. And it's harder for me to tell a compelling story that, well, if this program had been funded, those big insurance companies would have stayed. It seems like there are some markets that are just unattractive to insurance companies. They are rural and sparsely populated and not a lot of space to make money. And I think that's just a challenge the individual market confronted before the Affordable Care Act and continues to confront under the Affordable Care Act.
Those are Trump counties, I think.
Many of them are Trump counties as well.
Somebody over here? Yes?
Hey there, I'm Marty Felsenthal from Health Velocity Capital. I'm curious if anyone, Republican or Democrat, what we've been debating for the past 10 years is expand coverage or restrict coverage, but nobody's really talking about, I haven't heard a lot of people talking about affordable health care. I'm curious if you are seeing any movement out of Washington on either side of the aisle to really address the per unit, per person costs of healthcare, which are the most unsustainable part of the equation.
Yeah. I am not, and I think it's what makes healthcare incredibly, incredibly difficult. And it is why the Affordable Care Act struggles, and it is why whatever Republican plan will struggle is, like I was saying earlier, just the unit costs of healthcare are so incredibly high. So of course people are frustrated with their deductibles, and of course they're frustrated with their premiums that are helping pay for these, services that cost double or triple what they cost in other countries. And one of the things we haven't really done in DC is have a debate about actually limiting the unit price of healthcare. There has been a little bit of chatter around drug prices. Donald Trump surprisingly has been involved in that and has said things here and there about Medicare negotiating prices. We haven't really seen that moving forward. But I think it in part speaks to the power of healthcare lobbies in DC that anyone's overcharge is someone else's salary and someone else's profit. And it is, now that we've gotten to this point of having the highest healthcare prices in the world, it's very difficult to put that genie back in the bottle, because I think this is actually also a Chad Terhune story that had an amazing statistic that 1 in 9 Americans are employed in the healthcare industry right now. So if you want to cut prices, you're going to have to cut down on the number of people we're paying for in the health industry. And that's a trade-off we just have not been willing to discuss yet. But I think if we're going to come up with a healthcare system that works, it is hard for me to see how we do that given the prices that we have right now.
All right, I think we have time for maybe one more question.
Great.
Yes.
Hi, my name is Dan Mistek. I'm General Counsel at Community Oriented Correctional Health Services, or COACHES. We do federal policy, basically with trying to connect people in the criminal justice system with Medicaid. My question is tangentially related to that. So before President Trump was elected, we saw a lot of states trying to take advantage of opportunities that existed inside of Medicaid expansion. So for example, in New York, they were going to submit an 1115 waiver that would allow for all services, healthcare services, mental health services, substance abuse, behind the walls of the jail to be funded through Medicaid, which is an absolutely huge boon and important for our delivery system. Once President Trump was elected, they withdrew that. Yeah. Now they're putting that back in with that exact same things that they were going to put in with believing that Jason Helgerson was going to become head of CMS or whatever their ideas were. How much is the complete uncertainty that we see right now actually an opportunity that could be leveraged to improve our healthcare delivery system? And do you see states taking advantage of this chaos in order to try and improve their systems?
Well, so one thing I've been curious about in the Medicaid space is the way the American Health Care Act works is it would cap enrollment in 2020, but it lets states join the Medicaid expansion up until then. One thing I'd be curious to see if the bill did pass, if you'd actually have a few late entrant Medicaid expansion states who say we want to get some, we want to offload some of those unpaid bills. Let's start the Medicaid expansion now. For example, Kansas is a state that's really been back and forth on Medicaid expansion. They seem a few votes shy of overcoming their governor's veto. That might be the case that gets it over the finish line, that it's kind of has an expiration date. I kind of see the opposite happening. Well, I see experimentation happening more of because the type of waivers that this administration is going to approve are very different than the waivers the Obama administration was excited about. And this is one other area that isn't getting as much attention as the American Health Care Act, but I think is actually going to hugely overhaul how Medicaid works, is that there are a number of states who want to do, mostly conservative states, who want to test out things that have never been done in Medicaid through the waiver process. This includes things like a work requirement for being enrolled on Medicaid, capping Medicaid enrollment at 4 years, charging premiums each month. These are changes that under the Obama administration were a no-go. States would ask for them, the waiver request would get suggested. States would even say, well, we'll expand Medicaid if you let us make these changes. And the Obama administration would say, it's not worth it to us, we're not approving your expansion. A lot of those waivers were written in consultation with Seema Verma, who is now the CMS head. So there's an expectation that some of these waivers, that have been sent in already from Kentucky and Arkansas and Wisconsin will likely get approved. And I think that's really going to change the Medicaid program for years to come and really be a huge force, regardless of if a bill makes its way through Congress or not.
We are out of time, but I want to ask one quick question, which is not really a quick question, but try to make a quick answer. We have a lot of people here who are obviously interested in maintaining the best possible health care for as many people as possible. What do you think matters most in terms of influencing what is going to happen next in Washington? Is it the bully pulpit? Is it lawsuits? Is it policy? Is it, or is it just really bigger than California and, just kind of it's going to go where it's going to go?
I think when you talk to legislators, it's actually personal stories. I'll end with one story that because I think there's a lot of people wondering, how can I affect the process? There's so much policy making happening. What can I do to be effective? And there's this one story, Byron Dorgan, who used to be the senator from North Dakota, told me about, one time he changed his mind because of one constituent. And it was back in 2009 when they were working on the Affordable Care Act. And he had a constituent who was just showing up to all his town halls, calling him in Washington, visiting him in Washington, because she had a son with hemophilia who was running into his lifetime limit. And she had this high school son who had already used $1 million in healthcare and was running right up into running out of benefits. And she, just brought along her son. He remembered, she would bring photo albums of her son and say, this is a problem that we need to fix. And it was really that story that led Byron Dorgan to be the advocate for ending lifetime limits, and that part made it into the bill because of this one senator and because of this one mom who had advocated for it. And when I asked him, what lessons did you draw for that, he says, it's really the well-researched personal stories from constituents that make a difference when I'm thinking about legislation. So I thought that was kind of a nice story of how one constituent we have examples of them affecting the legislative process.
And the occasional late night host.
Yes,
like Jimmy Kimmel.
Exactly.
All right. Sarah
in California.
Yes, in California. Thank you so much for coming and making us smarter.
Thank you, Scott. Thank you, Sarah. Thank you both.